Hello everyone and welcome to my Opthal teacher. We'll be talking about cataract surgery and its complications in a series of video lectures. So we'll be dealing with part 1 today. Now, cataract surgery, as we know, is of the following types: ICCE, which is intracapsular cataract extraction, ECCE. ECCE is further subdivided into small incision cataract surgery, phacoemulsification, and the newer ones include femtolaser assisted cataract surgery, and the latest kid on the block is zeptocataract surgery. So, the basic principle, this is the structure of the eyeball. Now, this is the cataractus lens, for example, right? What is done in an intracapsular cataract extraction is that this entire structure, along with the lens capsule, is removed in toto, right? This structure over here, the entire capsular bag, this structure over here, the entire capsular bag is removed such that the anterior and the posterior segment become one continuous chamber. In such cases, it is obviously not possible to implant a posterior chamber IOL or an artificial IOL in the physiological position, that is, in the capsular bag. So, in this surgery, usually an AC IOL or an anterior chamber IOL used to be inserted in the anterior chamber, this part. So, this is the principle of intracapsular cataract extraction. Cataract extraction dates back to the time of Sushruth, who was the first to say that cataract is because of clouding of the lens due to proteins, and that surgery is the only known cure. The first picture is picture of Sir Harold Ridley, who first proposed the idea of an artificial lens implantation into the eye. This is the primitive design of the artificial lens proposed by Sir Harold Ridley. And the picture below is that of Sir Dr. Kelman, who borrowed the principle of phacoemulsification from dentists and utilized it to emulsify the nucleus of the cataractus lens, which we know today as phacoemulsification. Now, the main difference in all of these surgeries is the size of the incision. Couching is an ancient technique in which what people did was, this was way before surgery came into being. What was done was that a sort of hole was made in the eyeball, probably through the sclera, as there are no records available of this technique in scientific papers, and the lens was pushed into the vitreous cavity. Disastrous as the procedure sounds. Now, with the advent of modern surgery came intracapsular cataract extraction, which I have explained in the previous slide. Now, this involved a large incision of about 180 degrees, measuring about 14 mm. With further refinement in surgery came the technique of extracapsular cataract extraction and IOL implantation, with which came the advantage of a smaller incision size of about 12 mm. Then came the SICS, or the small incision cataract surgery, in which construction of a sclerocorneal tunnel was introduced. Now, this was self-sealing in nature and it was smaller, that is 6.5 mm. This really revolutionized the era of cataract surgery. And finally, there was phacoemulsification, in which a tiny 2 to 3 mm sized incision is used, and the emulsification machine using ultrasonic energy does most of the job. So, intracapsular cataract extraction at the time evolved into a very successful operation. And before the refinement of modern extracapsular surgery, it was the preferred surgical technique. But then there was a high risk of potentially blinding complications that have been mentioned here. So there were various techniques depending on the names of the scientists who designed them. And these are some of the techniques shown. So Smith's technique, for example. Now, this particular scientist used external pressure of a muscle hook to break the zonules inferiorly and tumble the cataractus lens out of the eyeball through the inferior limbus. Aruga's method. In Aruga's method, an instrument known as this Aruga's forceps was used. Now the capsule was held with the forceps and it was shaken or moved side to side such that the zonules would break and then the nucleus would be delivered easily. The indications of ICCE were only when the operating microscopes were not available. It was the only method of cataract extraction, and later on, as refinements came, it became limited to unstable or luxated cataracts and the cataracts with weak zonular support. And now ECC is obsolete. So, what are the problems? The problems are that, as we have seen, it has a very large incision which heals very slowly. There can be incarceration of iris, of vitreous, and there can be wound leaks in such a large wound. There is endothelial cell loss. There is more risk of cystoid macular edema, that is as high as 50%. There is vitreous loss, as we saw that the anterior and the posterior chamber become one continuous chamber. So obviously something from behind can enter the wound. It can enter the anterior part of the eye. So a lot of vitreous loss. As vitreous is lost, it exerts traction at its attachments, leading to retinal traction and possible retinal detachment. And there is no support for IOL. So the patient is left aphakic and has to wear either very thick glasses or contact lenses. So let us just briefly go through a short clip of ICCE. So here the surgeon is making the conjunctival peritoneal, and hemostasis is achieved with the help of bipolar cautery. A 15 number blade is used to give an incision just at the limbus, just outside it, followed by a crescent blade being used to simply enter the anterior chamber in a monoplanar fashion. That's the forceps. It's introduced into the AC. The capsule is held, and you see the surgeon is basically detaching it from the 360-degree zonular support. It's like breaking the zonules, right? With this to and fro motion. And you can see how hard the nucleus is in the complete cataract that is visible. Some viscoelastic to reform the anterior chamber. And now that the zonules have broken, a vectus is placed below the nucleus. The nucleus is engaged. See how big the nucleus is. And it is delivered through that large 14 mm incision. So you see that there is no possibility of placing the posterior chamber IOL in the posterior chamber, that is the physiological position of the lens, because there is no bag. So you, in such a case, you either place an anterior chamber IOL or a sclerofixated IOL, both of which were not available decades ago when this technique was devised. So why the shift happened? The shift happened when we got operating microscopes for better magnification and we got improved methods of cortical removal. Why was the shift necessary? To decrease the rate of potentially blinding complications and to facilitate placement of IOLs. And in ECC, the good thing was that posterior chamber was intact. Hence, anterior and posterior chamber were still separate, so there is decreased risk of vitreous loss and subsequent complications. The advantages of ECCE were that the incision was much smaller, it was less traumatic to the corneal endothelium, and it eliminated complications of ICCE. An intact posterior capsule allowed better anatomical placement of IOL and reduced the incidence of cystoid macular edema, detachment, and corneal edema. So in the subsequent classes, we'll be discussing about the extracapsular cataract extraction. And this was all about ICCE. Thank you so much for watching. All my presentations are available on my channel, which goes by the name of My Ophthalm Teacher. Thanks once again.